Hello, everyone. Welcome to Decreasing Unnecessary Demand. This is one of 3 learning modules addressing enhanced access. My name is Sarah Kerr, and I'd like to start out by telling you a little bit about my background. I have over 10 years' experience in nonprofit community clinics, including health center management, quality improvement, service delivery, and practice redesign. I'm currently serving as a practice transformation coach with the California Primary Care Association's Patient-Centered Health Home Initiative, and I look forward to spending the next hour with you. Before we jump in, let's review our learning objectives for this module. By the end of today's webinar, participants will be able to describe unnecessary demand and how it negatively impacts a practice's ability to become a patient-centered health home. Participants will be able to describe and implement key strategies used to decrease unnecessary demand. Participants will be able to identify and measure key indicators to ensure that unnecessary demand remains low. And participants will be able to understand how reduction of unnecessary demand enhances overall access and improves patient experience. Improving access is all about getting supply and demand in equilibrium, meaning there is no backlog of appointments and no delay between when the demand is initiated and when the service is delivered. The end goal is to be able to offer patients an appointment the same day they request it. In order to understand how to create this balance, we have to first have a clear understanding of supply and demand. Supply is the total number of appointments available on any given day. How many slots are on the schedule that could become patient appointments? Demand, on the other hand, is the total number of requests for appointments received on any given day. How many people contact you? Patients, other providers, recalls by your own providers, needing to fill an appointment slot either today or in the future. When supply and demand are in balance, the demands initiated today are met with the option for service delivery today. In other words, the practice is able to see all the patients needing appointments on the day the patient wants that appointment. The practice is able to do today's work today. That said, I'm guessing that this utopian vision of access might feel far from the current reality of many of your practices. The day-to-day experience of many healthcare providers is one of overwhelming and seemingly unending demand. The phones are ringing off the hook, the lobby is full of patients who've been waiting too long, the exam rooms are full of patients who've also been waiting too long, and the staff are in a perpetual state of just trying to catch up. It not only feels unlikely that we could ever balance supply and demand, it feels downright impossible. This discrepancy between limited supply and overflowing demand not only contributes to a delay in meeting patients' needs, but it can also be expensive, inefficient, and leads to staff feeling overwhelmed. But we shouldn't despair. Despite the seemingly unending demand, there are a variety of approaches a practice can take to narrow the gap. Let's start by looking at the different types of appointment demand faced by practices. Demand for appointments can be divided into external and internal. External demand comes in the form of new patients to primary care and referrals to or consultations with specialty care. Internal demand to both primary and specialty care comes from provider and patient-driven return appointments and may also include phone calls, faxes, emails, walk-ins, and return visits generated from appointments today. We can further dissect appointment demand by looking at the differences between necessary and unnecessary demand. We certainly don't like to think of any of the work we do as unnecessary, but when patient needs outpace available appointments, it becomes absolutely imperative that we take a close look at demand and determine if there are controls that we can put into place. There are systems and changes and efficiencies that we are generally not taking advantage of. Unnecessary demand is that low-hanging fruit. It is largely extraneous work that we create for ourselves through inefficient yet thoroughly entrenched systems. The remainder of the presentation today is going to focus on this unnecessary demand. What is it? How do we reduce it? And how by doing so, both the practice and the patients will benefit. So what exactly is unnecessary demand? Let's examine some different types of demand that could be considered unnecessary. Return visit too soon. Providers frequently develop habits and training that dictate how much time they allow between revisits for patients, especially those with chronic conditions. It becomes a mantra: come back in 2 months, come back in 3 months, or whatever the default return time frame might be. Patients who are scheduled to return based on a default rather than on true clinical need often don't know why they're coming back other than that the provider told them to. The visit doesn't always serve a clinical need, and when this is the case, the appointment adds to the unnecessary demand load of the practice. Duplicative care happens most frequently when a practice has poor continuity. When a patient is unable to see his or her primary care provider, they end up seeking care elsewhere. This could be with another provider in the practice, in an urgent care, or worst of all, the emergency room. Inevitably, the patient returns to the primary care provider to tell their story. The provider has to play catch-up and sometimes even make corrective actions, all of which could have likely been avoided if they'd been the one to see the patient the first time. This type of duplicate or rework care is a drain on the healthcare system. What about the mechanism of care delivery? Traditionally, most interactions between patients and providers has happened face-to-face. It's clear, however, that there are many patient needs that can be taken care of and services delivered via alternate methods. Unfortunately, payment systems haven't caught up with the technology and innovation of alternate care delivery models, making many practices wary of losing out on visit revenue. Even without payment reform, eliminating face-to-face visits where appropriate can save money in the end, especially if demand is outpacing supply in your practice. No-shows are the ultimate in unnecessary demand. An appointment that is scheduled and not realized is a missed opportunity. It inflates the perceived demand and ties up our supply. So how does unnecessary demand fit into the bigger picture? How will reduction of unnecessary demand assist a practice in becoming a patient-centered health home? Becoming a patient-centered health home means wholesale transformation of practice systems for most primary care organizations. But wholesale transformation ultimately entails a broad assortment of small changes in different aspects of the practice. California Primary Care Association's Patient-Centered Health Home Initiative has developed 8 key drivers to help practices move through this transformation in an organized and systematic way. These 8 key drivers represent the critical dimensions of patient-centered health home transformation. Each key driver includes multiple smaller actions and steps that describe the general direction for the change. Enhanced access is one of these 8 key drivers in the transformation to patient-centered health home. And reduction of unnecessary demand is an action step within enhanced access. As a key driver, enhanced access has 3 main change concepts: the provision of scheduling options that are patient and family-centered and available to all patients, helping patients attain and understand health insurance coverage, and our focus today, the promotion and expansion of access by ensuring that established patients have round-the-clock access to their provider or care team via phone, email, or in-person visits. One of the main tenets of this 24/7 continuous access is the availability of same-day appointments. In fact, providing same-day appointments is a critical factor in Standard 1, Element A of NCQA's Patient-Centered Medical Home Recognition Process. Element A is a must-pass element, meaning that you must pass this standard to qualify for PCMH recognition. Factor 1, same-day appointments, is what's known as a critical factor, meaning you must provide same-day appointment access to receive any score on Element A. Reducing the amount of demand makes it easier for the system to absorb current or future levels of demand. Reducing unnecessary demand not only makes same-day access possible, it makes it sustainable. Reducing unnecessary demand is a step towards changing the concept of same-day as urgent needs only to instead, everyone who wants an appointment today is offered an appointment today. Reducing unnecessary demand makes meeting Standard 1 possible, a required step in ultimately achieving NCQA, patient-centered medical home recognition. Reducing unnecessary demand is one spoke in the wheel of attaining enhanced access. There's good reason enhanced access is a key driver of patient-centered health home transformation. Patients like being able to see their care team when they need to. Not only does it increase positive experience in patients, enhanced access is also proven to improve health outcomes. Providers also benefit. They get to see their own patients in a timely manner, reducing duplicative care and increasing their effectiveness and overall job satisfaction. Providers who work in practices that have attained enhanced access consistently cite a decrease in daily chaos and stress. The practice also reaps the benefits in the form of decreased staff turnover, decreased patient complaints, and a more positive image in the community. Speaking of the community, the entire community becomes healthier as a result of enhanced access. Emergency room rates and hospitalizations decrease, which means healthier community members and less costly, uncompensated care being passed on to the taxpayers. These benefits have been realized by many, many practices who have successfully achieved enhanced access. Catherine Tantow, internationally recognized authority on access in healthcare, lists the following as the results of improved access. They include reduced delays for appointments, decreased urgent care and emergency room visits, improved continuity for both patients and physicians, improved clinical outcomes, enhanced compliance with mandatory guidelines, growth opportunities and financials, and increased patient, physician, and staff satisfaction. I hope that it's clear that the benefits of enhanced access are many, and that reducing unnecessary demand is one step your practice should take on the road to enhanced access. But how do you actually do it? When the rubber hits the road, what are the things a practice needs to do to reduce unnecessary demand? We're going to cover 6 key strategies today. Adequately managing panel size, decreasing no-show rate as much as possible, extending visit intervals when clinically appropriate, max packing visits, exploring alternatives to one-on-one visits for care delivery, and maintaining healthy relationships with specialists. Empanelment and appropriate management of panel size is a foundational element of patient-centered health homes. Empanelment creates an infrastructure that supports continuity of care, while management of panel size allows a practice to balance supply and demand and ensures that they can do today's work today. Panel size drives demand. When panels are over full, patients inevitably get deflected to other providers in the practice or other venues of care. This leads to unnecessary demand in the form of duplicative care when the patient returns to his or her primary care provider and either repeats the visit in whole or part as follow-up. When panel size is managed, providers are able to see their own patients, eliminating future unnecessary visits. Panel management is the ongoing monitoring, analysis, and adjustment of individual provider panels. At the outset of empanelment in a practice, it is important to run panel reports every month to review for outliers. Once the process is entrenched in the practice, a quarterly review of panel size should be sufficient. On an annual basis, the practice may elect to review provider supply for the upcoming year in order to ensure that there is enough appointment availability to meet the demands of the current panel size. It's important for the practice to designate a specific role and allocate sufficient time to that role to manage panels. Oftentimes, this task is assigned to a quality improvement coordinator, a medical director, or a site administrator. It matters less who has the designation of panel manager, but more that they have adequate training and time to do the work. The panel manager will continuously monitor key indicators and make panel adjustments accordingly. Provider status changes need to be taken into account. The panel manager needs to be aware of adjustments in full or part-time status, terminations, leaves of absences, and transfers, as well as the onboarding of any new providers. Patient status changes are equally as relevant. These include primary care provider assignment of new patients, death of current patients, and transfer of care upon request by either the patient or the provider. Additionally, if you work in a practice which includes pediatric care, there will be adolescents who need to transition to adult care. This generally affects whose panel they're assigned to. The panel manager also needs to continually assess the effectiveness of empanelment. The standard measures of panel effectiveness are the number of patients left unassigned at any given time and how often patients actually see their own PCP, also known as continuity. Both reports should be run routinely, monthly or quarterly as suggested, and trends should be evaluated at both the provider and the practice level, and interventions applied as appropriate to ensure a high degree of continuity. Based on the results of the monitoring, adjustments will need to be made to panels ongoing to ensure an equal distribution of work amongst providers and to ensure the benefits of empanelment are realized. The panel manager also assumes responsibility for comparing the panel size and anticipated demand for each provider on a routine basis. When there's evidence that a provider is overpaneled, the panel may be closed to new patients upon the discretion of the provider and the management team. You can find detailed information on panel management, including the guidance on data collection, in the Safety Net Medical Home Change Concept Implementation Guides on empanelment. I've included the website here and at the end of the slide deck for your reference. As mentioned earlier, no-shows are the ultimate in unnecessary demand. An appointment that is scheduled and not realized is a missed opportunity. It inflates the perceived demand and it ties up your supply. But this is unnecessary demand that you can't pre-plan for. It has to be out of the practice's control, right? Well, you can never fully eliminate no-shows. Though, anecdotally, I'm currently working with a practice that has an almost unheard of no-show rate of 0.5%. So it goes to show that there's always room for improvement, and there are strategies that you can use to reduce no-shows. No-show rates are frequently correlated with access delays and lack of continuity with primary care providers. Once you've undergone empanelment, no-shows resultant from these arenas will decrease de facto. It's a happy side effect of good empanelment and continuity. If you don't already have an appointment reminder system in place, get one. They are absolutely proven to decrease no-shows. Automated reminders are shown to be just as effective, if not more effective, than live calls. And, depending on the demographics of your patient population, email or text reminders can be even better. But beyond this, what can you do about people not showing up? It turns out there's a lot to be done. Know your patients. Some practices find that the actual number of patients who regularly no-show for appointments is a small percentage of their total patient population. If this is the case, the practice can find out more about these particular patients, determining if there are transportation, childcare, or other factors contributing to their appointment lapses. You may not be able to address all of these barriers, but until you identify them, you simply won't know. You can also look for bump rates. Are there spikes in the no-show rate that can be attributed to something that the practice is doing internally? Often, no-show rates are highly correlated with the number of appointments that are canceled by the practice. If the practice sends the message that the patient appointment is valued by reducing the number of practice cancellations, then this can have an impact on patient behavior in meeting appointments. Most practices don't want to cancel patient appointments, but often do when a provider calls in sick or other unexpected staffing shortages come up. It's important to map out what the policy and practice is in these situations and build systems to support an outcome that doesn't include appointment cancellations as a first step. You can also consider analyzing the types of visits for which patients are not keeping their appointments. Some practices find that recheck visits have the highest rates of no-shows. If patients don't see the value in a follow-up visit, they are less likely to keep that appointment. Providers can re-examine their return visit patterns and either eliminate unnecessary appointments or find alternative ways to check in with the patients, such as phone follow-up, email care, or follow-up appointment by mid-level clinicians. We'll talk more about visit intervals and alternate appointment options a little later on in the presentation. Extending revisit interval is an excellent way to decrease unnecessary demand. The interval for a return appointment depends on the individual patient's needs and on the discretion of the provider. A study at the Dartmouth Primary Care Cooperative Research Network found significant variation among revisit intervals by provider. The study found that physicians vary widely in their recommendations for office revisits, and that patient factors accounted for only a small part of the variation. Although individual physicians responded to visits in predictable ways, each physician appeared to have a unique set point for the length of revisit interval. Extending revisit intervals decreases unnecessary demand because fewer future appointment slots are filled. The Dartmouth study highlights how the habits developed by providers that determine when they tell a patient to return are frequently not based in clinical necessity or science. Extending revisit intervals where clinically appropriate has many benefits. In fact, a study published by the Journal of the American Medical Association showed improvements in emergency room rates, hospitalization, and patient satisfaction when the typical visit interval was doubled and telephone follow-up occurred between visits instead. Patients may be wary of providers asking them to come back in 4 months instead of 2. It's not a surprise. They've lost faith in the ability of the practice to grant them timely appointments. Be sure that you've worked on reducing your delays before you extend appointment intervals, and don't be afraid to tell patients what you're doing and why. Some practices have automatic return visits at standard intervals. For example, all diabetes patients come back in 1 month. Consider eliminating this process. Instead, base the clinical decision of return interval on each patient's clinical condition and status. Patients should be given a return appointment when it's needed and at an interval that is clinically meaningful. In order to do this, the provider has to make a decision based on the patient and the visit and communicate it to the scheduling staff. Develop a system that makes that easy for the provider. Some practices include revisit options on the super bill that the patient then takes to checkout. Some practices leverage their EMR to communicate to schedulers. Recently, I worked with a practice that implemented a simple wipe-away template that the patient took to the checkout desk to schedule a future appointment before leaving. It gave the provider options for revisit interval, and it also acted as a reminder to the patient to not leave without stopping at the appointment desk because the template was brightly colored, it was full-sized, and it was laminated, so patients weren't likely to stick it in their purse or shuffle it with their papers and forget. As mentioned before, providers develop their own unique habits and preferences for revisit interval. One way to reduce the variation among providers who see the same types of patients is to share information about return visit intervals as a means to promote discussion and dialogue, never as a way to impose and standardize arbitrarily. Involving the providers in a discussion about revisit interval allows for a collaborative process, increases buy-in to change, and ensures that revisit intervals stay rooted in the clinical decision-making process. If you're experiencing resistance or having difficulty getting all the providers on the same page, try a small test of change. Find a willing provider and ask them to increase their typical revisit interval for one patient, one time. Maybe extend the interval by a month. Track on that specific patient. What was the outcome? Were there any negative consequences attributable to the extended interval? Have that same provider try it with all their patients for 1 day or 1 week. Build up evidence to support the change. Providers are notoriously wary of extending visit intervals. The first argument that comes up is that by waiting longer between visits, we sacrifice quality of care and place patients' health at risk. This is exactly opposite of what we want to do. Extending visit intervals is only acceptable if it increases patient satisfaction, decreases waits for appointments, and maintains or improves patient health outcomes. Remember that a clinical decision about an individual patient is at the heart of revisit interval. When providers raise this concern, remind them what you're really asking for. For chronically ill but stable patients who return at regular intervals, consider extending their revisit interval. Patients with stable, well-controlled diabetes, hypertension, or chronic stable angina are all good candidates for this approach. Also, decisions to extend revisit intervals will depend on patients' ability to self-manage and seek care if and when their condition were to worsen, as well as the availability of urgent appointments. Keep in mind that as enhanced access is realized in your practice, More appointments will be available should emergent needs arise between visits. Another key strategy in decreasing unnecessary demand is max packing. Max packing is doing as much for patients while they're in the office for any given visit in order to reduce future work and, in many cases, eliminate the need for extra appointments. It's best accomplished by a patient's primary care provider because he or she has the background and relationship with the patient needed to maximize this approach. Last year, I worked with a pediatric practice who was able to increase their adolescent immunization rates while simultaneously reducing their delay for vaccination appointments by max packing sports physicals. The practice policy had always been to schedule vaccination appointments separately from sports physicals. They were inspired to try max packing the sports physical appointments when their QI data revealed that their adolescent immunization rate was below 30%. They began offering routine vaccination for young teens when they presented for a sports physical. This small change accomplished three things. It improved patient and parent satisfaction. It improved their preventative care because more adolescents got appropriately vaccinated. And it reduced unnecessary demand, thereby improving the practice's ability to see other patients in a more timely manner. Max packing takes planning and systems. We simply can't ask providers and their support staff to do more without providing them the tools to do it with. If your practice is interested in trying max packing, there are some basic tools you can employ. Staff can use a simple checklist of preventative care to anticipate a patient's future needs and take care of those needs today whenever possible. Does your practice have a registry or an EMR that tracks on routine care needs? Use it. Train staff to scan charts during a morning huddle to identify opportunities for max packing and plan their approach accordingly. Another option is to identify patients on the schedule who also have future appointments. Can you take care of all their needs today and eliminate that future appointment? This could be done during a huddle, or appointment makers can be trained to look for this when booking appointments and consolidate appointments under predetermined guidelines. Now let's talk about using alternate care delivery models to reduce unnecessary demand. Several types of interactions between providers and patients can take the place of a traditional one-on-one clinic visit. Most of these interactions take place over the phone, by email, or in a face-to-face group setting. Using some of these alternatives will decrease unnecessary demand by alleviating demand for traditional appointment slots and increasing efficiencies in workflow. There are often ways we can meet the needs of our patients without scheduling them a future in-person appointment. Despite the fact that these delivery modalities are often not reimbursable, if implemented in a thoughtful way, they can actually save a practice money while simultaneously increasing access to care. Use telephone contact to check up on a patient in lieu of an appointment. For patients who may need a follow-up appointment, develop a system where a member of the care team checks in with that patient by phone 2 weeks prior to when their follow-up appointment would have been. If the patient's condition warrants a visit, the appointment can be scheduled at that time. Otherwise, an additional follow-up contact with the patient can be scheduled and later made by phone. For those of you with a patient portal, use it to its full potential. Let me share a personal experience that highlights what I mean. A few weeks ago, I had my blood drawn. The very next day, I had an email telling me to log into the portal to view my results. And along with my results was a personal note from my provider explaining an out-of-range lab value and directing me to the appropriate follow-up. In the past, I would have had to return to the practice to get lab results. Not only would this have delayed receipt of the lab results, it would have also taken my time as a patient and filled an appointment slot unnecessarily. Patient portals can also be used for simple correspondence between patients and providers. Patients are often not sure whether or not they need to make an appointment. They don't know if what's ailing them is actually a problem that warrants a visit. Being able to shoot a quick email to your provider can frequently eliminate the need for an appointment. Of course, if the portal is going to be used this way, it's very important that the practice have allocated time for providers to interface with patients electronically and have clear guidelines about the use of the portal. Nurses can staff telephone advice lines or triage appointments. The practice can develop approved advice guidelines and standing RN protocols for basic health problems, such as UTI and suspected strep, or routine preventative care, such as flu vaccine, tuberculosis testing, and the like. Many practices are using automated systems to inform patients of normal test results. This eliminates unnecessary demand for appointments and frees up supply. Patients also appreciate timely notification that everything's okay. Group visits, in which several patients meet together with a provider and/or a care team, can be conducted. Group visits are an effective method not only for reducing demand, but also for providing increased continuity of care and a supportive social network for patients. In a group visit, the physician might meet briefly with the group, but the patient receives all the services of a traditional visit by utilizing other members of the care team. Of the alternate models we're discussing, group visits require the biggest workflow and infrastructure changes, so I'm going to spend a little more time on them. Group visits have recently captured the attention of primary care practices struggling to meet the needs of many patients who have ongoing issues and who are amenable to group formats. Research has shown that group visits help to improve access and quality in safety net hospitals and health systems and can be modified to fit the needs of your practice, providers, and patients. A group visit is not a support group in its typical form. It might include a 15 or more patient group and their caregivers in a 90-minute session. The session might include didactic presentations plus group discussion, self-management support accompanied by peer support. With training, planning, and support, almost any practice can start a group visit. Implementation typically starts with one provider offering one group, and as the practice works out the moving parts, it can then expand to more groups offered to more patients by more providers. Let's go through the key steps in implementing group visits. Before you can initiate group visits, you have to determine a population you would like to invite. Though basing a group visit on a common diagnosis isn't required, it is the most typical model employed. And in most settings, 30 to 50% of patients are amenable to participation in group appointments. So it's important that you make sure your population is large enough that if only a third of the people you invite agree to participate, the group will still be large enough to make the visit efficient for the team. Chronic illness registries and electronic health records or practice management reports can be used to identify specific patients to invite to a group. Be sure to secure a space. A typical exam room is not large enough for a group visit. You'll need to reserve a space where the group can interact comfortably, being sure to take into account any specific needs related to mobility, vision, and hearing of possible attendees. Some practices set up a larger room for the group interaction with a smaller adjoining or nearby room available for one-on-one consultations or privacy should the need arise. There are a variety of approaches you can take in structuring group visits. It's important for the practice to be clear about their group visit model before implementation. Will patients be required to have a group visit appointment scheduled, or will it be drop-in? Will the topics be pre-selected by the practice, then disseminated to the patients? Or will group discussion and interest lead the visits? Will you pull patients out for one-on-one mini-visits, or will all activities take place in the group? It may seem like a small and even obvious detail, but attendance at group visits is greatly increased if they are scheduled for a consistent day and time. This helps ensure stable staffing and allows patients to pre-plan their attendance. The group visit may be an entirely new concept to staff. It's advisable to choose staff who are proven innovators and leaders of change. Most group visit models include a provider, a nurse, and a medical assistant at the minimum. If the group is large, you may want to consider additional staff, but don't forget to keep in mind cost and efficiency. The format and flow of a group visit is quite different from a traditional office visit, and participating staff need to be well trained. Staff need to know what to expect and what will be expected of them. Training the team as a group is recommended, so all team members have the same baseline information and can learn collaboratively, mimicking the spirit of the group visit that they'll be facilitating. Recruit billing expertise to help you determine appropriate billing codes and documentation for group visits. Most E&M codes are billable in a group setting as long as chart documentation backs it up. Be sure to comply with any rules or regulations specific to your agency, your state, and your payers. Group visits require a substantial amount of planning. The steps outlined here are really just the basics, but there are a lot of resources to help get you started. I've listed a few at the end of the slide deck for your reference. A great starting point is the Group Visit Starter Kit, which is listed at the end of the slide deck, and you can find at improvingchroniccare.org. The last key strategy to reducing unnecessary demand that we're going to discuss today is formalizing relationships with referral providers. With the rise in patients dealing with multiple comorbidities and complicated chronic conditions comes a rise in patients who not only have a primary care provider, but possibly multiple specialist providers. Coordination of all these venues of care is vital in ensuring the best outcomes for the patient and in reducing duplicative care. And as we mentioned earlier, duplicative care is unnecessary demand. Forging formalized relationships with specialists can help both patients and providers by creating a structure to support increased collaboration and decreased duplication. But let's talk about the details. What are service agreements and how do we get them? Service agreements define the relationship between primary care physicians and specialists. They outline which conditions are appropriate for referral and spell out a process for making those referrals. Service agreements also set expectations for both parties. They delineate the workup needed so that the patient arrives at the specialty care appointment with all the necessary tests completed and ready for review. They also stipulate the expectations around timely care and communication between both the primary care provider and the specialist. Service agreements benefit both primary care physicians and specialists. Primary care physicians are ensured that their patients will be treated promptly by a specialist and that they will receive communication about clinical findings. Specialists are assured that they will see only those patients who require their services and that those patients will be ready for review, diagnosis, and treatment plan. It's important to note that service agreements are not guidelines or referral criteria that will be unilaterally disseminated from specialists to primary care providers. Rather, they are built-in partnerships between the PCP and specialty care venues. It may take some time and several conversations to build relationships and develop a service agreement. For this reason, primary care practices should consider focusing on one or two relationships at a time. The process begins with a conversation generally initiated by the primary care provider. Since the goal of the initial discussion and those that follow is to find common ground, the following principles should guide the interchange. Find common goals and work on them. Assume that all providers have the best intent for the patient's care. Avoid confrontation and focus on systems and not people. This final point is particularly important since changes to systems, such as the structure and flow of clinical information, is more effective than urging a colleague to behave better. The discussion might be considered important the discussion might begin by considering important categories of patients, such as patients who need an urgent referral, who need follow-up care after hospitalization, who need a procedure or need a consultation for an ongoing problem. For each patient type, both the primary care provider and the specialist should state and discuss their specific expectations. These expectations should cover which patients are appropriate for referral, information that the consultant needs before the referral, such as records and test results that need to be available prior to the visit, information that the primary care provider wants following the consultation. Does the PCP need a summary of care, or do they need copies of the entire specialist visit? Roles for both the primary care provider and specialist post-consultation. Will they be continuing to co-manage patients, or will the patient be discharged from specialty care and returned exclusively to primary care? Other processes, such as including such as the primary care provider not wanting the specialist to refer the patient to another specialist. Some primary care providers want to remain the hub of the patient's care so that they can ensure that they're getting all the relevant information about that patient's care and health. And if applicable, the use of an e-referral system. Service agreements take work, but they can solve multiple problems and make significant improvements, not only in the amount of unnecessary demand experienced as a result of duplicative care, but also in overall care coordination and patient experience. A thorough case study of one community clinic's experience in developing service agreements with specialists is available for your review in the Safety Net Medical Home Change Concept Implementation Guide on Care Coordination. You can see a snapshot of it here, and it's also included in the reference list at the end of the slide deck. It's a really great place to start if your practice wants to pursue service agreements. In summary, we've just covered 6 practical strategies that your practice can apply to reduce unnecessary demand. They are adequately managing panel size, decreasing no-show rate, extending visit intervals, max packing visits, utilizing alternative care delivery models, and forging formal relationships with referral providers. Of course, unnecessary demand will creep back in. Let's talk about ways to avoid backsliding, ways to ensure that unnecessary demand remains a small portion of your practice's overall demand. Measurement, keeping your eye on the prize, is key. It's difficult to measure unnecessary demand specifically, so it's important to continue to measure a variety of general access indicators to ensure you have a full picture of access at your practice. The key recommended access metrics are third next available appointment, demand, supply, no-show rate, and our panel metrics. I'll spend the next few minutes reviewing the details of these measurements. And accompanying this webinar is a document that outlines all of these measures for your ongoing reference. The standard measure of access across the country and across healthcare settings is third next available appointment. The name describes the measure well. Third next available is the number of calendar days until the third next available routine appointment. The delay for the third available appointment is used rather than the first or second, because it is a better reflection of your system availability. The first or second appointment may be available due to a cancellation or some other fluke event. Statistically speaking, the third is a more stable and reliable measure. How do we measure third next available? Start by picking a day and time that you will collect this measure every week. The most commonly chosen is Monday morning before the practice opens. Make sure that this task is delegated as a standing job function. Perhaps the front desk collects it, or the clinic manager, or even a medical assistant for each provider. The point is that it needs to become part of routine workflow. Use your scheduling system, whether it's computerized or manual, to count the number of days from today to the day when the third next appointment is available. You should only count routine appointment slots. Do not account appointments that are held out or carved out as same-day or urgent care needs, or appointments where the provider might consider squeezing in a double booking at the last minute. Remember that we're moving towards enhanced access, where all patients can get an appointment the day they want, not just the ones that a practice deems sick enough. Measure the third next available appointment for each provider in your practice. We want to know how soon a patient could get in to see his or her primary care provider. Continuity is important. A simple Excel spreadsheet can be used to track third next available. Some practices choose to track both a standard third next available for any routine appointment and a specific third next available if they have certain appointment types that are scheduled in specific slots and are harder to get, such as a sports physical or a women's annual exam. There may be fits and starts, with third next available being at 7 one week and then 2 the next, and then 15 when a provider goes on vacation. That's okay. You want to look for overall trends. If your third next available begins creeping up, it's a good indication that your unnecessary demand may also be on the rise again. As I mentioned previously, it's very difficult to specifically measure unnecessary demand, but we can measure demand as a whole. Demand can be calculated using this equation outlined here on the slide. It's a process which requires all staff who book appointments to capture information, and it's crucial data to have. A simple spreadsheet can be used with manual tick marks, or most practice management software can generate a report of visits appointed or booked on a given time frame. But let's go over the equation. Daily demand has three main components: phone call requests, walk-in requests, and return visits generated from visits today. The common denominator in all of these components is that the request actually results in the booking or scheduling of an appointment, regardless of the day the appointment is booked for. The demand for that appointment was initiated today, so the demand is recorded today. The reason you don't count appointment requests that don't result in an actual booking as demand is because those can become duplicated. The same request might be made 3 times in a week, inflating demand. You can certainly capture this data, but you don't want to include it in the demand total. There's yet another aspect of demand that's useful if you have the ability to track it. Deflections are patients who need an appointment who are redirected to another source and successfully get an appointment. It's hard, if not impossible, for some practices to collect this data, as you may not have the systems in place to know when deflections actually manage to get appointments at other venues. So this is an optional data piece, but it can help you work on unnecessary demand, as deflected patients will generally re-enter your system for duplicative care later on. And once again, duplicative care is unnecessary care. If you're collecting demand for the first time, you need to accumulate a month's worth to serve as a baseline. Then measure it monthly for a year, and after that, measuring it once a week, 1 week for 1 quarter should be sufficient to track on the changes. Capturing demand data and analyzing trends will allow you to plan for the necessary supply required to meet the demand on a daily and weekly basis. This data is really rich and can tell you a lot about possible unnecessary demand. Are deflections on the rise? Maybe panel size needs to be better managed. Are return appointment bookings increasing? Perhaps providers aren't using telephone follow-up as often as they could. Tracking on your ongoing demand will be key in holding the gains of any system changes you implement to decrease unnecessary demand. The demand measure will also be compared with your supply measure to give you a well-rounded picture of the practice's equilibrium between these two metrics. Supply is a calculation of the number of appointments available on a blank schedule template. Since achieving and maintaining good access is all about balancing demand and supply, we have to track both. To measure supply, you simply count the number of appointments on your appointment template by provider and by day of week. Be sure to revisit this measure monthly at a minimum, and any time that there is a major change to the schedule. The cardinal sin of data collection is never doing anything with the data you collect. So don't forget to chart out your supply and demand by provider. Share this information with the management team and with the providers. Are there days when providers have more supply than they do demand? How about vice versa, and there's more demand than supply? Use this information as an ongoing guide to inform change in your practice. No-show rate is a very important measure. Failed appointments are wasted supply. To calculate the measure, you simply tabulate the number of no-shows retrospectively each month and convert it to a percentage to establish the no-show rate. Most electronic practice management systems have a no-show report, and as long as staff are using the system in a consistent way, these reports are great. Let me tell you a little more about what I mean by the staff using the system in a consistent way. It's important to have a no-show definition that all staff understand and a procedure for no-shows that all staff follow. Some typical definitions are a patient's considered a no-show if they don't call to cancel at least 60 minutes prior to the appointment time and then don't show up. Other practices take a looser definition and only count patients who actually don't present for their appointment as no-shows. Whichever definition you use, If all staff are using the same definition, it ensures that any reports coming out of the scheduling system will represent clean data. You can use a run chart to display your data over time, so you can look for anomalies and trends. No-shows are the ultimate in unnecessary demand, so keeping a close eye on this measure is vital. The first of our 6 key strategies in reducing unnecessary demand was appropriate panel management. We covered the basics of what a panel manager should monitor ongoing to ensure empanelment success. I want to talk a little bit more about these metrics because they're also important on keeping your eye on unnecessary demand. Panel size refers to the number of unique or individual patients per provider. Care needs to be taken to avoid double counting patients who may have seen more than one provider. You only want to count patients who are actually assigned a primary care provider. If you're empaneled in your practice management system, this should be really easy to do and reports should be relatively easy to access. If you're not, the number might be available to you through a more manual system, and you could consider calculating the number of individual patients seen in the last 18 months for each provider, and that generally gives you a good reflection of your panel size. When a practice first begins empanelment, they should review panel size every month, but once patients are assigned, a quarterly review should be sufficient. Remember that panel size drives demand, so keeping panels in balance helps keep unnecessary demand low. And of course, we cannot forget about continuity. This metric refers to a measure of the frequency of patients seeing their own primary care provider when they come in for care. It's based on retrospective data. It's important to note that continuity does not refer to the number of patients on a given provider's schedule that are that provider's patients, but rather it's from the patient's perspective. What is the frequency that patients see their assigned primary care provider? This measure is done monthly and tracked over time, and each primary care provider's continuity should be tracked separately. For clarity, let's look at the equation used to calculate continuity. The denominator, or the total population that you're going to consider each month, is the total number of office visits of any one provider's panel of patients. In other words, how many times did Dr. Smith's assigned patients present at the practice for a visit last month? In this example, we're going to say it was 528. The numerator, always a subset of the denominator, is the number of those visits that were actually with Dr. Smith, 412. Convert this into a percentage, and you have continuity for Dr. Smith, 78%. If continuity begins to slip, it's quite likely that you'll also see a rise in no-show and unnecessary demand overall. I want to point you back to an excellent resource on panel management. The Safety Net Medical Home Initiative's implementation guides on empanelment outline detailed steps and offer helpful tools and tips. This resource, again, is included at the reference section at the end of the slide deck. With any change comes the challenge of change management. We should never underestimate the importance and the power of meaningfully engaging staff in system change. Changes implemented as a means to reduce unnecessary demand are no different. One of the foundational elements of staff engagement is sharing a vision. The practice needs to paint a picture of the possibilities. Staff need to know what patient-centered health home transformation is all about, why it's important, what can be achieved, and why they want to be part of that transformation. The vision can only be shared through open and ongoing communication. Our staff are the doers. They are in the health center every day, working with the patients, carrying out the mission. The best way to engage them is to talk with them. Make sure everyone knows the direction the ship is headed. And just when you thought you were done communicating, communicate some more. Develop systems that ensure information about change is continually communicated to staff. Less surprises means less resistance. We often forget that our staff have really great ideas. Give them a venue to share those ideas and be an active part of the change process. The receptionist has insights into patient flow that are different from the insights the medical assistant has, which are different from the insights that the provider has. Giving staff a voice to share those insights and work collaboratively with the team increases buy-in and engagement tenfold. Just like in elementary school, it's easy to fall into the pattern of only calling out mistakes or shortcomings and not routinely recognizing excellence. Engage staff in the reduction of unnecessary demand by recognizing great ideas and achievements. Did a provider increase their revisit interval? Tell everyone about their success. Did a phone staff person come up with the idea of adding the reason for visit to the reminder calls? Give her credit publicly. Positive enforcement goes a long way to encouraging and increasing staff engagement. And don't forget that frontline staff can be leaders too. We all know how ineffective top-down management is in the health center. When word comes down from administration of a new procedure or project, the knee-jerk reaction is resistance. If staff see their peers engaged in leading change efforts, their likelihood of being a help rather than a hindrance dramatically increases. We sometimes forget that our frontline staff aren't watching learning modules on enhanced access or attending conferences on patient-centered health home. We need to pass on the vision of transformation and give them meaningful ways to participate in it. In conclusion, I'd like to remind everyone of the main areas we've covered today. We've defined unnecessary demand and discussed how it fits into the bigger picture of patient-centered health home. We've reviewed 6 key strategies practices can use to reduce unnecessary demand. And we've talked about measurement and staff engagement to help ensure sustainability. On the path to patient-centered health home transformation, there are many steps. Reducing unnecessary demand is just one of them. I hope today's learning module has given you insights into how reducing unnecessary demand fits into the bigger goals, tangible tools to help you get there, and some resources to take away and share with the rest of your practice. Thank you very much.